Okay, well, it's 1 past 12 here, so why don't we get started? Thank you everyone for joining ATI rounds today. I have the privilege of having Ryaan EL-Andari from my lab present today. So before we start, we would like to acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continue to enrich our vibrant community. We'd like to thank Astellas for their support of the ATI seminar series and to highlight that on March 25th, 2026 will be the ATI Research Day. And we are pleased to have Kieran Cush from Stanford as our keynote speaker. And please register for this and submit your abstracts and encourage your trainees to present their research. So, as I introduced Ryaan here, Ryaan has completed his medical school training at the University of Alberta and is a fourth-year resident in the Division of Cardiac Surgery. Ryaan is currently pursuing a PhD in the Department of Surgery with research focused on optimizing ex vivo lung perfusion, or EVLP. His work aims to improve current EVLP protocols, allowing for prolonged preservation of donor lungs for transplantation applications. Ryaan is the recipient of the 2025 Jamie Fleming Graduate Studentship Award, and we'd like to give a shout out to Miss Nancy Fleming, who's attending today's seminar. Her generous donation in 2024 in memory of her husband, Jamie Fleming, has made this award possible. This award is open to all full-time graduate students registered at the University of Alberta whose research project is relevant to lung transplantation. So the title of Ryaan's presentation is Ex Vivo Lung Perfusion at the University of Alberta, Past, Present, and Future. I failed to introduce myself. I'm Jyan Nagendran. I'm Ryaan's supervisor and the surgical director of lung transplantation. So Ryaan, please, thank you.
Okay, great. So I'll go ahead here. So only disclosure I have is that my project is funded through the American Association of Thoracic Surgery Cardiac Surgical Resident Investigator Award. Otherwise, I don't have any conflicts of interest to disclose. And the learning objectives were sent out before, but really what I wanted to do with this talk is just talk to you about the utility and limitations of ex vivo lung perfusion. I want to talk about some of the key milestones of EVLP research and the ongoing initiatives at our center. And because of the University of Alberta's key role in both early lung transplantation and ex vivo lung perfusion, I want to talk a little bit about the history behind the field and where the University of Alberta fits in. And so just a little bit of background, I don't think will be a surprise to anybody, but lung transplantation is still the gold standard for patients with end-stage lung disease. And the field of lung transplantation has evolved greatly over preceding decades, as we'll see, although it's still limited in several areas. Number one is availability. About 4,500 lung transplants are performed annually around the world, although this doesn't meet the demand. This is because about up to 85% of donor lungs are rejected because of pre-specified criteria. And because of this, waitlist mortality for lung transplantation can be high as 15 to 20%. Preservation is another limitation. So currently we use cold static preservation, and this involves flushing the lungs with a cold preservation solution and storing them on ice for transportation until transplant. We can keep the lungs this way for 6 or up to 8 hours, but not much more than that. And during storage, you have cell death, you have worsening of lung function the longer that they're preserved for. We're also unable to assess organ function prior to implantation because they're sitting static in a box. Patient outcomes are one more limitation. Patient outcomes have undoubtedly improved over the previous decades, but primary graft dysfunction and rejection continue to be challenges in the field. So ex vivo lung perfusion describes a device that allows for the perfusion and ventilation of lungs outside of the body. And there's been several benefits shown with ex vivo lung perfusion. This includes longer preservation times, up to 24 hours in the literature. The longest being 36 hours actually was done at our center as well. It's allowed for recovery of marginal donor lungs, so lungs that otherwise would have been discarded, and successful transplantation of those lungs, showing one potential way to expand the donor pool. And finally, it allows for monitoring of lung function and administration of therapies during preservation. And it's not utilized at all centers, but it's clinically available and used at some sites. But ex vivo lung perfusion is still limited in some respects, and one thing is duration. So while we've prolonged duration up to 24 hours, there's select reports of preservation past 24 hours, and this limits our ability to recover donor lungs that otherwise wouldn't be used for transplantation. So things like patients presenting with pneumonia, pulmonary embolism, and trauma, these are things that would preclude their use for transplant. But if we can prolong preservation and improve these lungs, this could potentially expand our donor pool further. And so there's ongoing research at our center which aims to improve lung preservation during EVLP to address these limitations. But I wanted to talk first a bit about the history of the field and show how things have progressed over time, as well as how long those improvements have taken and where we're at today. So it's difficult to talk about EVLP without first discussing lung transplant. And a lot of the early work in lung transplantation was focused on surgical techniques and used canine or feline models. Dr. Carrel in 1907 was the first to describe a heart-lung transplant in which he took a heart-lung block and implanted it into the neck of a recipient cat. In 1946, Demikov transplanted heart-lung blocks and right lower lobes in dogs. And he was able to do this by maintaining, without cardiopulmonary bypass, maintaining blood flow to the brain, except for a short 2 to 3 minute period. And he was able to do this by using quick connects and over tubing in order to connect all of the vasculature without interrupting the blood to the brain for too long. And he did these heart-lung transplants in 67 dogs, if I'm not mistaken, and only 6 of them survived and recovered, showing how challenging these procedures were at the time where the technology was limited. In 1950, Metris performed the first successful sequential double lung allograft transplant using a bronchial anastomosis in a dog, and this bronchial anastomosis is still the technique that we use today in most cases. And in 1951, Juvenel performed auto lung transplantation in dogs looking to study innervation of the lungs. In 1955, E.D. Thomas was able to extend survival of lung transplants in dogs from 7 to 16 days without immunosuppression up to 300 days using immunosuppression, which included methotrexate, transfusion of donor blood, and irradiation. And he took from his experience treating lymphoproliferative disorders in order to guide his use of immunosuppression in these cases. In 1960, the Eurocollins preservation solution was created, and in 1961, Blumenstock and Kahn demonstrated that methotrexate helped to improve lung allograft survival in dogs. So now we move to 1963. James Hardy performed the first isolated left lung transplant in a human patient, and this patient presented with pneumonia, emphysema, squamous cell carcinoma of the left lung, and importantly, renal disease. He used azathioprine, prednisone, and radiation to suppress the immune system in this patient, but this patient only lived for 18 days and then died of renal failure. Really interesting in this case, the patient was actually serving a life sentence in prison, and there was sort of an understanding between the patient, Dr. Hardy, and the state that if he was able, the patient, to contribute to advancement of human technology and progress, that there would be a favorable attitude toward changing his sentence, but unfortunately he only survived a couple of weeks after transplant. In 1968, the first heart-lung transplant was performed by Denton Cooley. This patient only survived for 14 hours, and 5 months later, Dr. Walton Lillehei reported the second heart-lung transplant, which lived for only 8 days. In 1969, cyclosporin was discovered. It was found to be an immunosuppressant with minimal cytotoxicity, and the use of cyclosporin-based immunosuppression facilitated early heart-lung transplants in primate models and was shown to also improve tracheal healing by the Toronto group, which we'll come back to in a little bit. So by 1978, there were 38 known lung transplants, only 9 of these patients surviving more than 2 weeks, and the longest being 10 months. There was a case of a single lung transplant performed in a 19-year-old in Toronto. They died of bronchial anastomotic breakdown. There was another case of a patient who survived several months. And one of the key reasons why these anastomoses were breaking down were because of immunosuppression. And so there was one patient who received up to 2 grams of methylprednisolone for 20% of his first 100 postoperative days. And this was one of the main reasons why these anastomoses weren't healing. In 1981, what's considered the first successful heart-lung transplant was performed by Dr. Rates, Dr. Shumway, and Dr. Walwork in a 45-year-old patient with pulmonary hypertension. And in the 1980s, we developed Fujimura low-K dextran solution, which eventually led to the development of Perfidex, which we use today. Moving on to the Toronto group. So in 1983, is what's widely considered the first successful lung transplant was performed by Dr. Cooper and colleagues. This was a right lung transplant in a 58-year-old with pulmonary fibrosis. And in 1986, Dr. Cooper and Dr. Pattison performed the first successful on-block double lung transplant for a 42-year-old patient with end-stage emphysema. These were performed via sternotomy under full cardiopulmonary bypass, and they also used an omental wrap around the tracheal anastomosis. And so it took all the way until 1983 and 1986 until these cases were first being done successfully. And around that time at the University of Alberta, the thoracic transplant experience began here. So in 1986, the first heart-lung transplant was performed at the University of Alberta in a patient with congenital heart disease and pulmonary hypertension. In 1986, the first single lung transplant was performed at the University of Alberta. And in 1990, the first bilateral lung transplant was performed. Notably, in 2001, the first lobar transplant was performed at the U of A. This was only the third in Canada, with the first procedure having been done all the way back in 1990. This procedure was done by Dr. Starnes at Stanford in a 12-year-old patient who received a right upper lobe from her mother. And so moving on now to ex vivo lung perfusion, the history of EVLP, well, ex vivo organ perfusion goes back almost as far as in the field of lung transplant. So in the 1930s, Lindbergh, who was actually an aviator from the World War, met up with Dr. Carrel to start this research. Lindbergh had a sister who suffered from valvular heart disease, and this couldn't be repaired because they didn't have cardiopulmonary bypass at the time. So he met with Dr. Carrel, who described earlier as doing the first heart-lung transplant in a cat, which was implanted in the neck, and they designed an ex vivo organ perfusion chamber. So they were able to perfuse organs in an incubator, including hearts, kidneys, thyroids, ovaries, unfortunately not lungs at the time, but show that they could maintain organ function for several days. However, these weren't transplanted. In the 1980s, Hardesty and Griffith used coronary otter perfusion to preserve bovine and canine heart-lung blocks with successful transplantation. Those are the pictures on the right there. So really, they created autocirculation in which the heart was pumping to the lungs, which then returned to the heart and allowed the block to perfuse itself to allow for further transport and transplantation. And by 1987, they had published a series of transplants using this preservation technique. In the 1990s, Steen and colleagues developed an apparatus to assess lungs after explant and prior to transplant, and in 2001, this led to the first ex vivo lung perfusion transplant in a 54-year-old donor, which received a single right transplant going to a 54-year-old with COPD. Moving on now to the Toronto experience. So the Toronto group has published extensively on their ex vivo lung perfusion program. And in 2008, Sippel and colleagues reported the technique for prolonged normothermic ex vivo lung perfusion. They did this in pig lungs and human lungs, and the pig lungs were eventually transplanted. In 2011, they published their clinical series. This was on 23 donor lungs perfused with EVLP, with 20 transplanted. They had rates of PGD grades 2 or 3 of 15% in the EVLP group and 30% in the control group. And a year later, in 2012, they published their experience with the first 50 ex vivo lung perfusions in clinical transplantation. So again, with the Toronto group being one of the one of the biggest groups, if not the biggest group in ex vivo lung perfusion, publishing their series starting in 2012. Again, not long after the University of Alberta ex vivo lung perfusion program started. So in 2013, we had the development of the first negative pressure ventilation EVLP device and Canada's first portable EVLP device. And this led to the first EVLP lung transplant at the University of Alberta. And this actually used rejected donor lungs. This was published in 2014. The donor was a 69-year-old female who was in a motor vehicle collision. Their preoperative PF ratio was 267. And one of the main issues was contusions and lacerations on the lung that required a wedge resection and some other repairs. The recipient of this patient was a 65-year-old female with IPF. And here's a video of one of the early devices from our center that we've used. Moving on to 2015, published a series from our center that used 3 donor lungs that were also that were DCD donors and 3 recipients that all underwent transplant between 2014 and 2015. In 2015, the same year, there was a case report published from our center that used DCD lungs with large pulmonary emboli, which were recovered using ex vivo lung perfusion with thrombolysis during EVLP to recover the lungs, and these were eventually transplanted into a 29-year-old with cystic fibrosis. A couple of the other studies I want to highlight from our center, there's a 2017 study by Abul Nazar and colleagues in JHLT, and here they compared using both human and porcine lungs that were perfused and either used positive pressure ventilation, which is kind of the standard and what most other EVLP devices use, versus negative pressure ventilation, which is what we use. The difference being that positive pressure ventilation is kind of what we use as standard in intubated patients, where you're pushing the air in and pulling the air out. Negative pressure ventilation, the lungs are in a sealed chamber, and you change the pressures inside of the chamber to draw air in or push air out, more similar to how we breathe. In the negative pressure ventilation group, there was higher compliance, lower cytokine production, less bullae formation, and less edema than with positive pressure ventilation. And the negative pressure ventilation devices that you see here are still what we use today. Butchko and colleagues published in American Journal of Transplantation. This was looking at comparing total parenteral nutrition versus the standard glucose supplementation for metabolism during ex vivo lung perfusion. And TPN improved inflammatory markers, PF ratios, and stabilized electrolytes during EVLP, which we still use as our standard for the longer duration runs. In 2020, there was a clinical trial that was published from this center as well. This was in Nature Communications. It's a single-arm trial that used negative pressure ventilation EVLP to recondition a dozen donor lungs for transplantation. For the donors, the average age was 43 years old. Causes of death included intracranial bleed, overdose, and cerebrovascular accident. 9 patients were NDD donors, and 3 patients were DCD donors. The average PF ratio before transplant or before EVLP was 234. For the recipients, the average age was 58 years old. The indications for transplant included emphysema, talcosis, IPF, alpha-1 antitrypsin deficiency. The lungs were perfused for 2 hours in 7 of the 12 cases and 3 hours for 5 of the 12 cases. This was sufficient to recover these 12 lungs enough for transplantation. The ICU length of stay was 5.3 days on average. No patients needed post-transplant ECMO. There was no cases of PGD grade 3, and 1-year survival was 100%. And so since the inception of the program at the U of A, this EVLP program has published many times on the research and, more publications than I could go through in this hour. But one thing to highlight is a recent publication on the longest duration of EVLP at 36 hours. And a lot of the work that's shown here has been imperative in improving our understanding of ex vivo lung perfusion and lung preservation. So there's ongoing research at our center, which aims to improve our understanding of ex vivo lung perfusion, lung preservation, and improve our current protocols, aiming for longer-term preservation of donor lungs and better recovery of lungs. So going back to a little bit of background, primary graft dysfunction, or PGD, complicates anywhere from 30 to 80% of lung transplants, maybe a little bit lower at our center, but that's about the average in the literature. And PGD is associated with increased rates of short-term mortality and the development of chronic lung allograft dysfunction in the long term. The pathogenesis of PGD is multifactorial, but it includes donor characteristics, recipient characteristics, operative characteristics, as well as ischemia reperfusion injury, which is centrally associated with. After ischemia reperfusion injury, there's a formation of reactive oxygen species that results in cellular injury, injury to the endothelium, and activation of proteolytic enzymes. And so there's several problems with EVLP that I think are all related. One is ischemia reperfusion injury. Another is inflammation, which occurs when the blood contacts the circuit, as well as hemolysis, which happens when the blood goes through the arterial filter or the deoxygenator. There's edema formation during EVLP runs. Again, limited duration of preservation above 24 hours, and continued findings of PGD following lung transplant. And it's likely an interplay between all of these factors. So there's a nice summary figure of ischemia reperfusion injury published in a review by Chen and colleagues in 2021. Really what I want to highlight here is starting on the left at ischemia, both the hypoxia and changes in mechanotransduction lead to a cascade of events that include degradation of ATP, formation of reactive oxygen species, and these will eventually result in endothelial injury, procoagulant effects, platelet activation. There's inflammatory markers that are increased, and a potential for no reflow syndrome in cases where thrombosis is formed but isn't broken down. And so what we wanted to do with some of the experiments of my PhD was try to target specific parts of these pathways to reduce the negative effects of ischemia reperfusion injury, hopefully improve lung function, and then this could eventually be translated to reduced rates of primary graft dysfunction and a better understanding of preservation. And so these are the areas we hope to target, being leukocyte activation, pro-inflammatory cytokine productions, and thrombosis. So this is a summary figure that I made that I think takes you through the cascade of events that happens. Starting in the top left, you have your donor patient that has some sort of acute illness, whether this is a massive stroke, cardiac arrest, or a trauma. They're at higher risk of thrombosis and also have high rates of inflammation around the time of that acute illness. The organs are then procured and stored. You have depletion of oxygen, breakdown of ATP, and accumulation of these toxic metabolites. You also have inhibition of normal function of ion transporters and accumulation of intracellular calcium and sodium, which contribute to edema formation and also contribute to the formation of reactive oxygen species down the line. You then reperfuse the lungs, either during ex vivo lung perfusion, which you still have an ischemia reperfusion injury, along with some other things like inflammation and hemolysis, like we discussed, or they go straight into the patient. And either way, you get these formation of reactive oxygen species. You get damage to the DNA, to endothelium, and to cells themselves. This results in primary graft dysfunction, which results in worsening outcomes for the patients. And so we designed experiments focused around changing things in our ex vivo lung perfusion protocol to, again, address specific points in this pathway. And so I'll describe to you our standard ex vivo lung perfusion experimental setup, and then we'll go through each of the changes that we made in our experiments. So the model we used was a juvenile Yorkshire pig, and you're aiming between 40 and 50 kilos. We procured the lungs from the pigs using a sternotomy, and we also anticoagulated them with heparin prior to taking the lungs out. We collected blood into a cell saver, and we used packed red blood cells in our perfusate. And the composition of our perfusate was a common hospital ingredient perfusate or chip that we make in-house, packed red blood cells, heparin, piptazo, and methylprednisolone. We use negative pressure ventilation on these lungs, and we with lung protective ventilation. We perfuse them at 38 degrees Celsius and at 30% of predicted cardiac output, with an evaluation performed every 3 hours. And the standard protocol that we use is during these evaluations, we increase the cardiac output to 50% for the evaluation. Each group had an N of 5, and each experimental group had a modification either to the perfusion parameters or to the perfusate itself. And so this is just a summary of the experiments that we did. So we took the lungs, put them on the EVLP machine, and made one of these 4 changes, one being a modified flow parameter, one being antiplatelet agents, immunosuppression, or mesenchymal stem cells. So we'll start with talking about cardiac output and its impact on lung function during EVLP. So standard EVLP protocols have either used 100% of calculated cardiac output, so this is what's predicted to be normal for the animal, or moderate cardiac output targets anywhere from 30 to 50%. High cardiac output targets, close to 100%, have been associated with increased edema formation and early failure of lungs, and the same is true with very low flow protocols, which largely result in early lung failure. Comparison of cardiac output targets in the past have generally favored a moderate cardiac output target, again, between 30 and 50%. Our center's protocol, to review it again, is 30% during preservation, with an increase to 50% every 3 hours for our evaluations. So in the control group for this experiment, we left it like that, 30% for preservation, increased to 50% for 5 minutes every 3 hours. In our experimental group, we left it at 30% for the duration of the run, with an evaluation performed still every 3 hours, but without a change in cardiac output. And really the rationale behind this was anecdotal findings that each time we increased the cardiac output, the lungs got a little bit worse. And there's a lot of literature showing that if you leave them at those high cardiac output targets for a long period of time, they don't do as well. So we thought maybe if we cut these changes in cardiac output out, we could improve lung function. And here's what we found. We have 2 charts here, dynamic compliance on the top, minute ventilation on the bottom, and these are over the 12 hours of preservation. The black line is the control group, the blue line is the experimental group. And we found that both dynamic compliance and minute ventilation were significantly improved when we took that extra increase in cardiac output out compared to the control group. We also noticed that both dynamic compliance and minute ventilation started to trend back downwards after 6 hours, where this wasn't the case in our experimental group. Here we have pulmonary vascular resistance in the top left, PA pressures in the top right, and PF ratio in the bottom left. These weren't significantly different between groups. In the bottom right, we have lactate formation. Now, this wasn't statistically significant, but there was a trend towards a difference here where the control group's lactate continually climbed, whereas in the experimental group, this plateaued after about 6 hours. We looked at enzyme-linked immunosorbent assays, looking for pro and anti-inflammatory cytokines. We really only found one significant difference, and this was in IL-18, which is a pro-inflammatory cytokine that was higher in our control group. So more inflammation in the control group here. Next, we'll move on to discussion of antiplatelets during ex vivo lung perfusion. So we already discussed that ischemia reperfusion injury is a key component of primary graft dysfunction, and thrombosis at the time of procurement or after transplantation can exacerbate these ischemia reperfusion injuries, preventing reperfusion of some segments of the lungs and prolonging ischemia time. In general, higher rates of platelet accumulation and thrombosis result in worse outcomes during EVLP. And the picture on the bottom right there is a review that we published this year in Transplantation Direct, that looks at the literature for studies that have focused on thrombus formation, platelet activation, or antiplatelet use during EVLP and lung transplant. This is generally what they found, is that higher rates of platelet activation, more thrombosis, worsen outcomes on the lungs, and if you treat them with antiplatelet agents or break down those clots, the lungs tend to do better. So for our control group, again, we had our standard EVLP protocol, and the experimental group received a loading dose of dual antiplatelet agents in the form of aspirin and ticagrelor. And here we have similar charts. So again, in the top left, we have dynamic compliance. This was significantly improved in our experimental group, where again, the control group started to decline after in this case, after 9 hours. Pulmonary vascular resistance was also significantly improved in the experimental group. PA pressures, PF ratios weren't significantly different, and lactate, we saw a similar trend where the lactate climbed more rapidly in the control group compared to the experimental group. On the far right, we have a chart showing weight gain, where we had a reduction in weight gain of the lungs, so edema formation in the antiplatelet group compared to our control group. Here we have the results of our enzyme-linked immunosorbent assays. Really, again, there's only one significant difference, which is an IL-1 beta, which in fact was higher in the dual antiplatelet group compared to others. Things like IL-18 and IL-12 were trended towards being higher in the control group, but this was not a significant difference. Move on to talking about mesenchymal stem cells. So like I mentioned, EVLP is effective for lung preservation, but there's still some inflammatory response from the blood just contacting the circuit during perfusion. Following ischemia reperfusion injury, the pulmonary vascular endothelium is damaged, and this results in increased permeability of the endothelium and subsequent edema formation. Mesenchymal stem cells have been used in other settings for their anti-inflammatory effects. They reduce inflammation. And so we thought in this setting, they could potentially improve lung function by reducing this inflammation and reducing graft dysfunction. So for our control group, again, was the same. So our standard ex vivo lung perfusion protocol. For our experimental group, we collected mesenchymal stem cells using an iliac tap from pigs who had undergone lung explant for other experiments here. We cultured the mesenchymal stem cells on a culture plate. Once they reached confluence, we split them, and we continued splitting them until we had a sufficient number of cells for this experiment. The target that we had was 100 million cells total, so 50 million stem cells injected into the pulmonary artery at 2 time points, so at time 0 right at the beginning, and T6, which is about halfway through. Surprisingly, only 4 of the lungs that received stem cells actually made it to 12 hours. So we had 1 lung failure early in the protocol to get up to an N of 5, and we still could not get that lung to 12 hours. So we had 2 early into the lungs. We had sort of an immediate inflammatory reaction where the lungs went bright red. But again, this was just anecdotally, but it manifested as these lungs failing early. For our parameters here, there were no significant differences in compliance, pulmonary vascular resistance, lactate formation, PF ratio, everything was similar. Minute ventilation technically reached significance with a p-value of 0.048, but was very close to our cutoff here. But otherwise, there were no significant differences. In our pro-inflammatory cytokines, IL-8 tended to be much higher in the MSC group compared to the control group, and other markers of inflammation were not significantly different. We'll next talk about immunosuppressive agents, so I don't think I need to belabor the point here at this group especially, but just very briefly, prednisone, prednisolone, methylprednisolone, they're currently used in lung transplantation and ex vivo lung perfusion. They prevent T cell proliferation, decrease macrophage activation, inhibit cytokine production. Calcineurin inhibitors like tacrolimus or cyclosporin are also used as part of triple therapy in lung transplantation. They also prevent T cell proliferation and transcription of IL-2. There's nucleotide blocking agents like mycophenolate. This also reduces proliferation of T and B cells by preventing replication. And we have induction agents that are also used in lung transplant that I won't go into here because we won't touch on them in these experiments. But really the rationale here was we use these additional immunosuppressive therapies. We're not using them in lung transplant. We're not using them in EVLP. If we add them in, can we help to blunt some of these inflammatory responses? So in our control group, we had our standard EVLP, which includes methylprednisolone that's added to the perfusate as our standard. And in the experimental group, we added a calcineurin inhibitor in the form of tacrolimus and mycophenolate to the perfusate in addition to the methylprednisolone. Now, in these experiments, we found a significant reduction in pulmonary vascular resistance here, with no differences in PA pressure, minute ventilation, or dynamic compliance. Weight gain was also similar between these groups. And we had no significant differences in pro-inflammatory cytokine production, although some trends towards actually higher inflammation with immunosuppression. So, to summarize, our work has demonstrated that stable ex vivo lung perfusion parameters in terms of not increasing cardiac output, as well as the addition of antiplatelet agents, is effective in improving lung function during ex vivo lung perfusion. The addition of immunosuppression helped to reduce pulmonary vascular resistance during EVLP, but didn't necessarily improve anything else for the lungs. And the use of stem cells did not improve lung function in the protocol that we used. So modification of our current protocols to change the flow parameters for stable cardiac outputs and the addition of antiplatelets may help to improve preservation and prolong ex vivo lung perfusion. So, which is what we plan to do next, is incorporating these into our standard protocol. We also have other areas that we're hoping to explore in our lab. These include things like preservation of the endothelial glycocalyx. So this is the layer that's between the endothelium and the blood flow that prevents movement of ions and movement of large molecules across the endothelium. Preserving the endothelial glycocalyx may help to prevent edema formation and improve lung function. We want to prevent or treat reactive oxygen species formation to mitigate their adverse effects during preservation. We look to hopefully improve preservation solutions, which can again hopefully prolong the time that we can preserve lungs for. We also want to develop models of organ recovery. So things like I mentioned, aspiration, pneumonia, trauma that would prevent us from transplanting lungs in a clinical setting. If we can create models of that, then we can potentially show that with longer preservation, we can recover these lungs for transplant. And finally, putting all of this together, we hope that in the future we can facilitate long-term organ preservation and even potentially organ banking to help to address the donor shortages in lung transplant. I thank you all for your attention. Yeah, I'd like to thank everybody, my supervisors, people from the SMRI, our other lab members, and all this funding support that I've gotten for these experiments, and I'm happy to answer any questions.
So a very, very big congratulations to you, Ryan, and for a fantastic lecture, and to Jane and the team for an amazing amount of work. I mean, just behind every one of those experiments is a massive amount of surgical skill, and those are very demanding studies. So you really should be very highly congratulated on that. It was an amazing tour de force. So
Thank you very much.
of all the different opportunities that you presented there and interventions, which do you think shows the most promise for rapid clinical translation?
So I think there's two. I think the easiest one to implement would be the one on cardiac output targets. I mean, these are things that we don't have to administer to patients, that we can easily change. It actually doesn't require really any additional supplies, so we can incorporate that today into a clinical ex vivo lung perfusion setting. The antiplatelet agents as well, I think, are going to be really key moving forward. And I think this is both for lungs and outside of lungs. I mean, the inflammation, the thrombosis that occurs, this happens in any donation setting, and so could impact other organs as well. The question is, where do we administer these? So with antiplatelets, of course, post-transplantation, we're going to worry about bleeding in these patients, so we're not going to give it to them on post-operative day 0. But we can incorporate them. We can incorporate them into the ex vivo lung perfusion protocol, and given enough time, we can hopefully break down those thrombi and improve these lungs. So I think those two are going to be really key, and they've shown the most benefit in what we've shown so far, and hopefully we can continue to push those two changes forward.
Thank you.
Thank you for those kind words, James. And then Kieran Halloran, Dr. Halloran, who's also on the PhD committee, supervisory committee of Ryaan, and we appreciate his support in our research too.
Great work, Ryaan. I've seen some of this data before, but it's fantastic, very well presented too. I know you both know, you and Jyan both know, but just for everybody else, 10C storage has come along and has really changed the way that organ preservation is happening. So I'm wondering, what are your guys' thoughts on when we think about the way that EVLP is implemented in many jurisdictions in the world now? When I talk to people about their EVLP experience at different centers, when we think about the way that it exists now, what's going to be the future role of EVLP? Is it preservation? Is it therapeutics? Is it logistics? Is it transport? Or are a lot of those, now roles that 10C storage can occupy, and EVLP is going to occupy a different niche? And do you think, the secondary question is, do you think that the current utilization of EVLP internationally is justified?
Thank you so much, Dr. Halloran. I think those are excellent questions and really important to think about when we're talking about these types of experiments and clinical use of EVLP. So to answer your first question, for prolonged storage with the 10C fridge, I think that the utility of EVLP solely for prolonging storage is not really there. I don't think we can justify the cost by increasing our preservation times from 6 hours to 12 hours to 24 hours. Really, once we're past that, once we're at the point where we have our 10C fridge that we can preserve lungs for 10 or 12 hours, the transportation, preservation, keeping them until the morning, all those benefits are there. We don't really need ex vivo lung perfusion for that anymore. And it's obviously more cost effective. I think the point or the key benefit with ex vivo lung perfusion is some of these things that we're showing where we can potentially recover marginal donor lungs. So the prolonging of preservation up to 24 hours doesn't really give us that ability. We've shown with that clinical trial, or not we, but Dr. Nagendra has shown with the clinical trial in 2020 that even preserving lungs for 2 or 3 hours can help to improve marginal donor lungs. The ones that I'm really interested in are the ones with pneumonia, with aspiration, the ones that need more than that 2 or 3 hours to recover, where 24 hours would not be sufficient. Where I see it in the future is if we can preserve lungs for 3, 4, 5 days and keep them stable, we could take a donor that is otherwise healthy but maybe has a pneumonia, put them on the machine, give them lots of antibiotics, give them time to recover, treat the pneumonia, and then transplant them. And those are organs that we could never utilize today. There's even a paper published this year for prolonged preservation where they cycled between cold static preservation and ex vivo lung perfusion. They were able to preserve lungs for up to 3 days. But it's a 4-hour period of EVLP, so you're not recovering the lungs, and it's also very hard to see what they're doing over that time. So we can put them in a fridge maybe for 12 hours, but we still can't assess the organ function. So if we're taking marginal donor lungs, we might not be able to utilize those just with the 10C storage. So I think those two things of one is assessment of function, marginal donor lungs, and two is recovery of a larger pool of donors will be the big benefits for EVLP moving forward, but we need to improve preservation first.
Thanks. And Dr. Halloran Sr., Dr. Philip Halloran, please.
Well, listen, I'd just like to congratulate you on really a wonderful series of experiments and a very fine body of work. My question really is that we've been very interested in you've touched on this actually, you're calling marginal donors, but we're really looking at the effects of aging and trying to establish how aging relates to the transplant performance. We see in kidneys and hearts, there's a remarkable amount of inflammation and parenchymal deterioration in people on the basis of age. And I think that the possibility that this interacts with preservation strategies has to be considered. And it's very difficult to model because it really can't be studied in animals. What are your thoughts about the interaction between aging, which is a challenge for all donation now, and your preservation problems?
Yeah, thank you so much, Dr. Halloran. A great question. So I totally agree that there's probably some sort of interaction between aging and some of these other things like inflammation, ischemia, reperfusion injury, and it may be that donor organs coming from older patients might be less resilient to some of these insults. I mean, if we could optimally preserve these organs in a setting where we don't have these insults, then we could potentially expand the donor pool where those smaller insults might damage the donor organs, the lungs enough that they're not able to be utilized. And so that's why, even working through the experiments that I planned from before, learning a bit more about ischemia, reperfusion injury, primary graft dysfunction, it's become a little bit clear to me that there are other processes going on, like ischemia reperfusion injury. And if we can address ischemia reperfusion injury, prevent reactive oxygen species formation, or at least remove those reactive oxygen species before they can damage the donor organs, then we can improve the preservation, potentially expand the donor pool into coming from donors that have a little bit less reserve in those organs and may not be able to tolerate being put on an EVLP machine or other ex vivo organ perfusion device prior to transplant.
I might add to that comment, Dr. Halloran, in that, with our lab being multi-organ perfusion, we do see the sensitivities to ischemia reperfusion injury being somewhat organ specific as well. And the lungs tend to be relatively resilient. And so we have, and clinically, we have used very old I shouldn't say very old, that's the wrong word, older donors with ages, I think Kieran might correct me, I think a 75-year-old is I've used, I believe, in a non-smoker and otherwise healthy person who was active up until I think the day he fell off his ladder. For that reason, the metabolic demand in that either ischemia period or that reperfusion period, which I think is primed by age-related dysfunction or inability to cope with that increase in reactive oxygen species or that initial ischemia reperfusion phase is what requires mitigation in aging. And it may be not as robust a finding in the lung cohort, which we're fortunate for, as you know very well, kidneys and hearts with high metabolic demands are unforgiving in that setting.
Well, could I just comment that, in fact, I think many people are pushing the envelope on the age issue, and in particular in hearts and in kidneys in Europe are much more likely to be transplanted when they're old, and they work. They don't work as well. And the question really is how the customers feel about that, and is it a good clinical result? But they work, and I think that you're in a position to help push the envelope here to try to make better use of the organs that are available and not discard them on the basis of some age-related rule.
If I could just jump into the donor age and the primary analyte that you guys are interested in, which is primary graft dysfunction, it's a complex kind of literature, and it's not super clear that it's a really strong PGD risk factor. There were some studies that have shown that, but other studies have kind of failed to confirm that. And I think a lot of centers are kind of looking at it as a sliding scale. And I know that Leuven just did a nonagenarian lung donor that they published, because the reality is most of us die with our lungs, not of our lungs, right? Lung function probably does decline with age, but whether or not they're more vulnerable to PGD, I think, is a specific question. I don't know that it's really convincingly shown. I think we are compellingly seeing that lung function is lower in those patients. Best achieved lung function is lower in a patient who receives older donors, but whether or not primary graft dysfunction and the whole cascade of ischemia perfusion injury is augmented by donor age, I don't know that we know that. It'd be interesting if you guys can stratify on that based on your analyses. I know that it's hard to look at age in these experimental models, and whether how closely an animal model will translate and the effects of age will be complex. But with discarded donor lungs, it's an interesting question that would be worth analyzing. But I don't know that it is heavily involved in this specific cascade.
Great. We have a few more minutes if there's I see Dr. Hergy, Aline.
Hey, Ryaan, that was a great presentation, and like John, I actually really appreciated the history of lung transplant that you had at the beginning there. I learned a few things, so that was excellent. I was looking at some of that data that you shared about the use of dual antiplatelet therapy, and it was just really impressive to see the improvements in compliance and resistance as well. And you sort of alluded to this, but definitely you could, this is the same process probably happening on all organs in terms of endothelial activation and thrombosis formation at the time of ischemia reperfusion. And so do you know if there's been similar studies that have been done in ex vivo perfusion with some of the other organs, and if you've seen similar benefit? Maybe it's measured in a different format, but it'd be interesting to know if that's been looked at. And I don't know if you know the body of literature outside of lungs, but it definitely would be interesting to consider that. And sorry, Ryaan, I know you're speaking there, but we can't hear you for.
Yeah, your mic is cut out there, it looks like.
Can you hear me now?
Yeah.
Yeah,
Okay.
we can hear you.
Yeah, so yeah, I think it's a great question, and I think I kind of mentioned it very briefly earlier, but I believe that the same process would be ongoing, and the reason is there's no real difference in the cascade that happens. So if you take a heart or a liver or a kidney, you still expose it to ischemia. You're still going to have buildup of toxic metabolites from ATP, a lack of oxygen. You're going to reperfuse them, and you're going to form those reactive oxygen species. And the same thing is, I think that one of the key pathways that this is mediated by is damage to the endothelium, increased edema formation. And while the parameters maybe are different, I think the process is likely very similar. I don't know the literature very well offhand. I mean, I haven't come across a lot of literature in other fields for ex vivo organ perfusion on this in my reading, but I suspect that we would see something similar. So if you can prevent thrombus formation at the time of prior to donation, or if you can more effectively break those thrombi down during ex vivo organ perfusion, reperfuse earlier, you're number one, reducing the amount of ischemic time. So hopefully, reducing the ischemic burden on even some of those distal vascular beds, reperfusing earlier, and then preventing some of this damage that happens. So my hypothesis is that if you do the same thing, treat with antithrombotics or some sort of fibrinolytic, that you'll have the same response in other organs. But I think definitely that needs to be trialed in an ex vivo organ perfusion setting and then eventually in a transplant model.
Great. And then Dr. Ann Halpin from HLA Lab.
Hi, thank you so much. That was such a great presentation. I learned a lot. I'm absolutely not a surgeon. If my button falls off my shirt, I have a problem. So anyway, really commend you for this excellent work. My question is going to be a little HLA focused, not too HLA focused, don't worry. But I was thinking about the mesenchymal stem cell experiments that you talked about. And you didn't really kind of circle back to them in the summary, but I'm just wondering, I know sometimes we see in the HLA lab, a patient has gone typically to Mexico, gets some kind of treatment for something, comes back, and we don't fully understand the allogenicity of these types of treatments for third party. I think this was from a different pig, correct? If I understood your experiment correctly, and obviously you weren't looking at allogenicity specifically, but I'm just wondering if you looked at upregulation of MHC, or I guess SLA in this case, or other things like with that. Why do you think that didn't go well in your experiments, or if that was my understanding of your description of it? And do you have any thoughts on allogenicity of those therapies if we're going to incorporate them into ex vivo perfusion?
Yeah, that's a great question. It's something I've thought about, and we haven't looked into it specifically for a couple of reasons. One is that these are all inbred pigs, so they're genetically very similar. So, I mean, I'm assuming that it should be similar from one to the other, and we're pulling these stem cells from sometimes from more than one pig. But yeah, so they should all be genetically similar, but haven't actually confirmed that. The other thing is we've done some of these experiments in other settings in our lab where we've exposed in humans allogeneic stem cells as well as autologous stem cells to their blood. And we found that the blunting in the immune response was very similar between the two because they're so high up the chain that, they're not recognized by the immune system the way that, the solid organ transplant would be. Now, I'm sure that if you can match them perfectly, maybe there would be something different. In my reading, what I found is that when you just inject stem cells on their own into the lungs, that it's variable what the benefit is. So that actually a lot of studies show that there is no benefit in ones that have done something similar, either in a transplant setting or an EVLP setting. And sometimes it's products of the stem cells, like extracellular vesicles derived from stem cells, that provide some more of that benefit. So it may just be the model that we were using. I think we use a sufficiently high number of stem cells, 50 or 100 million during the cycle being among the highest that's been done in the literature. But so it could just be that what we're injecting maybe is not optimal. So it could be some product of stem cells that we can isolate down the road that may provide more benefit. But that's my best thought, is really maybe it's not the stem cells themselves, but something they're producing.
Yeah, thank you so much. So you think they're the same SLA typing most likely if they're related, or do you think there could be MHC differences between them, or probably not?
I would assume because they're inbred and genetically they should be very similar or identical, that they would be the same. But again, I think we would have to confirm that to see, and maybe that's one potential explanation we haven't looked into yet.
I'm not offering to do SLA typing or anything in the lab anytime soon, although there are people who do that. All right, thank you.
Thanks so much.
Great. Well, thank you. I think it was a great job, Ryaan. I'm very proud of all the work you've done in the lab and all the trainees before you as well. We're privileged to have such motivated, hard-working trainees who do this great work. If that's all, I don't see any other hands up. I think I'll thank everyone for taking the time to join us today, and hope everyone joins next week as well.
Thank you, Dr. Nagender, and thank you everybody again for the opportunity to speak to you. It was a pleasure.